Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and welcome to our CATHIP, Health Hour session on this lovely Saturday. It's still sunny, and I'm sure many of us are enjoying the Platinum Jubilee celebrations. This morning, we're looking at a really hot topic. It's very much a concern, across so many quarters. It's in the media as well, and as many of you know, we're really delighted to have our health professionals from our own community giving their time every Saturday morning. So the CATHIP sessions are organized jointly between the Caribbean African Health Network, RAFA, International Development, Black Health Initiative in Leeds, Croydon BME Network, Royal House, Redeemed Church in Sheffield, and the Croydon BME Net Forum as well. So we're really grateful for you taking time off during this celebration to learn a bit more, because knowledge is power. And this morning, we're delighted to have one of our own. She hosts some of the sessions at times, but she's also the sexual health clinical lead for the Caribbean African Health Network. But she is a consultant in sexual health. And Dr. Vanessa Apea will be giving us an insightful session on monkeypox. Over to you, Dr. Vanessa Apea.
Thank you so much, Charles. And I'm just going to share my screen, and then we can start. Great. I'm hoping that is full screen.
I think you need to put it on the slideshow. So the little button just before the 67%.
Okay, so it's okay. Let me try again, because I clicked slideshow. Apologies, everyone. So, is that working?
So I think, Vanessa, it's just that button before the 67 at the bottom. If you press that, it should go into the full mode.
Yeah, I clicked it. I've clicked it. Let's see, is that working now?
No, but we can still see the slide, so we can crack on.
Oh, bear with me. Sorry, everyone. We did it before. It was fine. Not quite sure.
If you just click the icon slideshow and then say from the beginning.
Yeah, no, yes, I am. It's just not doing it for me. Bear with me. Let me. That's not? Sorry, Charles, is that?
No.
No, it's not a food show, but yeah.
Sorry, Charles, is that working or?
Not yet.
Sorry, everyone, I don't know why this is happening. We'll get there. It's full on my screen, but it's not on your screen?
No.
Right.
But I mean, we should still be able to. Yeah, that's better. Yeah.
Is that okay, everyone?
Yeah.
Yeah.
Apologies.
Good.
Sorry, everyone. I don't know why it's not working, because it was working just a minute before. So, good morning, everyone, and we really appreciate you being here. I know that it's a busy weekend for all, but I think this, as Charles says, this is a really hot topic. It's something that has been taking over my life at work and many of my colleagues. And I was also saying earlier that normally when I'm giving presentations here, there is so much information I want to share in such a short space of time. But today, one of the key things is that we're still learning about monkeypox. And so I'm going to give you the information and insights that we have so far, and then really want you to have an opportunity to ask me any questions, and I will do my best to give you the information that we have so far. So as Charles says, I'm a consultant in sexual health and HIV, and a lot of my work recently has been revolving around monkeypox, and I'll explain more as I go through. So this is about monkeypox and what we know so far. So first of all, what is monkeypox? Well, it's a virus, and it's a close relative of smallpox, and the virus that causes smallpox, which is the variola virus. But it's not as severe as smallpox and has a lower mortality. And when we've known about monkeypox before, it primarily occurs in Central and West Africa, but there have been exported cases that have been linked to travel in recent years. And the first monkeypox case was reported in Central Africa in 1970. So loads of people ask me, first of all, like, why is it called monkeypox? People feel quite uncomfortable by the name. But the thing is that it was first identified in the laboratory monkeys, the macaques, in Denmark in 1958. And so that's why it was given the name monkeypox. And however, it's interesting because monkeys don't seem to be the natural host of the virus. And it's actually more commonly found in rats and mice and squirrels. The first case in humans was seen in the 1970s, as I said, and that was in the Democratic Republic of Congo. And so when we talk about monkeypox and we talk about it being in Central and West Africa, we use the term endemic countries. So it's there, but it's kind of hovering around, the levels may not, that we record, don't tend to go over 2,000, it's kind of contained. And the endemic countries are outlined here. So it's Benin, Cameroon, the Central African Republic, as I said, the Democratic Republic of Congo, Gabon, Ghana. In Ghana, it's been identified in animals only. Ivory Coast, Liberia, Nigeria, Republic of Congo, Sierra Leone, and South Sudan. So these are the countries that we've been regularly seeing it in. And if you look at the table at the bottom there, that is from the World Health Organization. And it gives you kind of a, again, I think it's important for people to have it in context in terms of the numbers. And so we have Cameroon up until February of this year, over the past year has been only 25 cases. In Central African Republic, between March and April, there were 6. In DRC, from January to May, you see some of the higher cases of over 1,000, and in Nigeria, between January and April, 46. And I think also what's important is when we look at the deaths, we can see that it varies in the proportions of it. But you can see in Cameroon, you only had 25 cases, but there were still deaths, but they were less than 5. And similarly in the Central African Republic, and 57 in DRC. So why the concern? Why has all this conversation and anxiety come up about monkeypox? Well, I've used the term endemic, so it's been in countries and it's been contained there. But since 13th of May this year, we've had cases that have been reported in countries that are not endemic for monkeypox, so outside of those countries that I've mentioned. And the key thing is that there's been no established travel links to those countries. So if we, the thing about viruses, the thing about, can't help but mention COVID, but one of the things that COVID really emphasized to us was that how globalized the world is, and how much travel occurs. And so because of that, we see infections and viruses, moving globally. And you can understand it because you can see, if you can see a link with a country, you can say, okay, we can see how the virus has moved. But for monkeypox, where it has been contained in certain countries, the ones that we've seen in the UK and other areas, there was no established links to these countries. And based on the currently available information, and I emphasize this, is that cases have been mainly, but not exclusively, been identified amongst men who have sex with men, and when they've been seeking care in primary care and sexual health clinics. And so prior to this, just to put it into context, 7 cases of monkeypox were in the UK between 2018 and 2021, so only 7. 4 of these were imported, so related to travel. And then 2 of these cases were household contacts of these cases that were imported. And 1 case was a healthcare worker involved in the case of one of the imported cases. So you could see the network, you can see how it originated. And this is why there is concern at the moment, is because they're in countries not expected, groups not expected, and it's trying to understand how did this happen. So if we look at the current UK picture, so this is very much like COVID as well. When we used to give the talks about the awareness about it, one thing that was always really important was to highlight that so much work is going on in the background to keep an eye on everything, to model it, to monitor it. And that's what's been happening here. And so if we look at in England, just up until the 30th of May, so we're constantly getting information. So we had 183 cases as of the 30th of May. And you can see that the biggest cluster is in London. And then the next highest is around the southeast, and then in other areas as well. And then those that are unknown, we can see 27 there, their addresses had not yet been confirmed. But as of Thursday, there were 214 cases in England and across the UK. So we've now started to see cases in Scotland, Northern Ireland and Wales. So the total in the UK as of Thursday was 225. So what are the signs and symptoms? So we say that it's any unusual rashes or lesions on the body, such as on the face or in genital area, but can be all across the body as well. A fever, which we typically talk about greater than 38.5, muscle aches, intense headaches, joint pain, back pain, lymphadenopathy, chills and exhaustion as well. So all of these can be symptoms and signs of monkeypox. And they usually begin about 5 to 21 days after exposure. So after someone has been exposed to someone that has monkeypox, the symptoms will normally come about within the 5 to 21 days. And that 21 days is what we've been using to say that, to try and understand those that could be potential contacts. And so people will normally present with an initial illness of fever, malaise, the lymphadenopathy, which is the swollen lymph nodes, typically can be in the neck or in the genital area, and a headache. And then within 1 to 5 days after these initial symptoms can come up, then a rash develops, and it often develops and begins in the face or the genital area, and then spreads to other parts of the body, and particularly arms and legs. And this rash can, and the appearance of this can typically change over time. So generally, they can start off as flat or a bit raised, and then they evolve into vesicles. So these are fluid-filled blisters and pustules. So sometimes it looks like pus has gone into those blisters as well. And sometimes they can have like a central dip. So we call it umbilication. So it dips down. And then these eventually can burst and crust over, and then they can fall off during the next 2 to 3 weeks. And as I describe that, I can bet you that many of you are thinking, gosh, you know, this sounds like chickenpox. And that is very true. And that's one of the difficulties of this, because I don't know if many of you know, but there is currently a lot of chickenpox going around. So there is a lot of anxiety about, right, we've got a new virus, but also a virus that looks like something that is very common. And so that is why we are raising awareness, but also encouraging people to just have that index of suspicion. So if you do have these symptoms, do speak to your GP, speak to 111 to discuss if you need further testing. And also, you know, over COVID, one of the things that has come out even more is that, you know, when I went to med school, a lot of the images that we would see were either all in Black people or all in white people. And you would never see it, you would rarely get images of how it would present in people of different skin colors and shades. And we've highlighted that it is so important that we have this. And one of the other things is that because monkeypox is typically endemic in Central and West Africa, you know, a lot of the images are those that are in Black people. But we know that as it has come out into other countries, that it is presenting in all skin shades and colors. And we are seeing a lot of it in those of white ethnicity as well. And so what's been really important is getting these images out that don't just have only the images of those that are in Black skin, that's showing it on white skin and other colors as well. So when you look on here, these are your typical signs and symptoms. And, you know, as I said, it's really difficult because some of these you would see, you know, this, I don't know if you can see my screen, but I'm pointing to the second on the top row. And, you know, this can just look like a spot that we would typically have anywhere on our bodies. And you can look across and you can see some of them look like pustules and they're raised, and then you can see how it looks when it scabs off as well. So these are the typical presentations that we're seeing. And what's been really important in within monkeypox, and again, I keep making reference to COVID, is the importance of sharing information, the importance of people coming forward and then us piecing the information together so that we can understand what is happening. And so this is one of the early reports that have come out just to describe what has happened previously. And when we look at these images here, you can see again, just shows us that that these can look like any number of things, and we may have seen them something similar previously as well. So it's just getting these visual representations of this. So people are often asking, and my family are saying, why are you involved in monkeypox? What has it got to do with your work? And particularly within sexual health and HIV, there are many infections that can mimic how monkeypox presents in these blisters and skin changes. So syphilis can look like this, herpes can look like this, chickenpox, as I've said, and shingles can look like this. So these are things that I will see every day in clinic. And actually what has happened is that people have presented thinking that it is a sexually transmitted infection, thinking that it's something like, excuse me, gonorrhea that has spread. And so they presented, and then it's been recognized, okay, this isn't a typical presentation of that sexually transmitted infection, or they have got a sexually transmitted infection in addition to monkeypox as well. So it has made us it's raised significant awareness that we need to exclude this when we're seeing people within our clinics. And so it's something that we are managing day to day within sexual health. Now, I mentioned earlier that it's a relative of smallpox, and people are saying, we had smallpox and then we had a vaccine. Why wasn't the same efforts put into things like monkeypox? And one of the key things about monkeypox as compared to smallpox is that it tends to be a milder disease. So it's usually mild and self-limiting and settles by itself. And most people recover within a few weeks. But like anything, it can also be severe and result in death as well. And some of the complications that I'm highlighting here is secondary infections and getting quite severe chest infections. So bronchopneumonia, sepsis, so infections spreading around the body. Encephalitis, so inflammation of some of the brain matter as well that can cause confusion and headaches, and infections of the cornea within our eyes that can cause loss of vision. So it is definitely mostly a mild disease, but you can have severe cases. And so that is why it is crucial that we contain this current spread that is happening. And when we look at mortality and we look at those that have died from monkeypox, we are basing our knowledge and understanding from cases and experiences that have happened in Africa. And sorry, the cases that have been identified, pardon me, so far in the UK are from the West African clade. So it's the West African type. And this has been reported to have a mortality of about 1%, so 1 in 100. But there are varied reports, and so sometimes you see it go up to 6 to 10% that is reported, but it's mostly been reported as relatively low. So again, when we think of this as well, the key instinct for us to ask is, how is it passed on? So it's passed on from close contact between people. And so it can occur when a person comes into contact with an animal, human, or materials that have the virus. And the virus enters the body through broken skin, even if that broken skin isn't visible, through the respiratory tract, or through mucous membranes. And what we call those mucous membranes are those soft linings within our mouth, within our nose, and within our eyes as well. And it can, so when we think of it in this way, we can see that the virus can be spread through touching monkeypox skin blisters or scabs, touching clothing, bedding, or towels that are used by someone with the monkeypox rash or monkeypox itself, and the coughs or sneezes from a person with monkeypox. So it's droplet transmission. So it's not aerosol that's just within the air, you know, similarly to COVID, it's droplet transmission. And the key thing is that the infectious period starts from the onset of symptoms and it lasts until the scabs have fallen off. So I described that people may get this initial, sometimes what we call is a prodrome. So they get these initial fevers and arthralgia, so pain in the joints and feeling unwell, and then this then progresses to a rash. But the infectious period is from the onset of those symptoms and until that rash that evolves into blisters and it bursts and it gets the scabs, the scab is still infectious. So until those scabs have fallen off, we call that the infectious period. And just again to reinforce that I mentioned that you know, when you're exposed to someone, it may take anywhere from 5 to 21 days for you to develop symptoms after you've been exposed. Now, because we have seen these early predominant cases amongst men who have sex with men, it's a lot of myths are starting to evolve around it. And one of the things is that trying to understand about, you know, that it's primarily sexually transmitted. And we're unclear about whether sexual transmission itself, how it's contributing. You know, I've said that it's close contact and we have close contact in sex. So it's not necessarily the sex, but it's because of the close contact within sex and intimacy that results into the transmission. So we are still understanding whether sexual transmission is contributing. But we do know that transmission can occur via the placenta from mother to fetus. And so there is congenital monkeypox. And so the key people that when we are particularly concerned about when we're thinking about those that have been exposed or potentially exposed, could be potentially exposed, are those that are immunocompromised for any number of reasons, and those young children and those that are pregnant. So these are key groups that we see as at higher risk of having more complications. So how are we responding? What are we doing? How are we keeping things at bay? So one of the key things in all of this, and whenever that you have any outbreak or increase in cases, is that we need to find those cases. And for me, you know, I'll talk about the stigma later, but what worries me with a lot of anything that has stigma related is that it stops people from coming forward. And people often will tend to suffer at home and have something that requires treatment and review because they are have been shamed by the stigma around it. And this is why, you know, platforms like this, and when we have conversations like this, it is so important that we arm ourselves with knowledge, and then we recognize that people need to come forward if they do have symptoms so they can be managed and supported. And then we can also minimize the risk of their infection being passed on to someone else. And that is the only way that we are going to be able to contain the current transmission that is happening. So I'm just putting the definition of a probable case because it's what we're using within clinics to try and identify people and screen people for monkeypox. So anyone with an unexplained rash that can look like chickenpox or syphilis on any part of their body. And if they have also another one of the classical symptoms that I've talked about in terms of the fever, the headaches, the joint pain, etc., since the 15th of March of this year, and either have a link to a confirmed or probable case of monkeypox in the 21 days before they gotten symptoms, or if they've had recent travel to West or Central Africa in the past, in the 21 days before their symptom onset, or they are a man who has sex with men. So if anyone fits into these criteria, then we are deeming these people as a probable case, and they need to be tested, and they will be treated and supported as if they do have monkeypox until the result comes back to confirm that they're negative, and we're sure that they're not at risk of acquiring it within those 21 days. And I'm sure, you know, when I was talking about this yesterday to family members, you know, they're like, well, you know, I may have a fever or a bit of a rash and arthralgia, pain in my joints, and I've just come back from Ghana, and I'm thinking it's probably malaria, etc. And that's right, it's probably more likely to be malaria. But at the same token, when we are in an outbreak like this, then it is important to monitor things and keep on top of things. And so we are advising people that if you fall into these categories, please don't hesitate to contact 111, to contact your GP, or to contact your local sexual health service. But I'll go through what to do in a second. And just to know what happens is that we do a specific type of testing, so PCR, but what that means is that we take a swab, and we take swabs from the skin lesions and from the throat, and we take blood tests as well. And these tests are sent to what's called the Rare and Imported Pathogens Lab. So we call it RIPPLE, and it's the UK Health Security Agency, which used to be Public Health England. They have a lab at Porton Down, and this is the designated laboratory. So in any centre, we are sending our samples to this lab so it can be tested for monkeypox, because it is a highly infectious organism, and so there are specific regulations in how it's managed and how it's sent, etc. And so the other thing that comes up a lot is, okay, so if I do have monkeypox, what happens? And so the treatment is mainly supportive, and at the moment, monkeypox is a highly infectious disease, and when someone is diagnosed, then they are managed, and there will be discussions to see whether they need to be admitted. They may be admitted because of their symptoms, if they're in severe pain, if they're extensive blisters, and they've got other complications, they may need to be admitted into designated units, or they may be able to be managed at home, but will need to be called daily. And so we've been managing people that are well with it, and can be managed at home with what we call virtual wards. So, you know, for example, today I am contacting those that have monkeypox and are isolating at home to check in on their symptoms and to make sure that everything is okay. So that is what we're doing. Some are admitted and some are being managed at home. The other thing is there are some people that are being admitted or have specific management because they are they don't have extensive symptoms, but they are unable to isolate from those that they are living with, or they're living or they're living with people that are immunocompromised. So there may be someone that's living with someone that has cancer and is on chemotherapy, and someone living with HIV, someone on an inflammatory bowel disease that they're on steroids, extensive steroids. So if they are unable to isolate from their housemates, then this may warrant admission. But overall, most treatment is supportive, and it's focused on easing symptoms, managing complications, and preventing long-term consequences. And so there's a lot of focus on skin care, eye care, and mouth care. And there are a number of antivirals that I'm not even going to start to say. I can say Cidofovir, but too early in the morning to say some of the others without stuttering. But there are antivirals that may have activity against monkeypox, that they're not widely available. We do have some, and some patients are requiring treatment. So we do have treatment there. But the majority of people will not require these antivirals. And these antivirals themselves, some of them are quite toxic in themselves. So it's all about risk, benefit, and management. And that's also part of the reason why those that do have monkeypox and are unwell are in specific designated units. Vaccines. So people have been asking a lot about vaccines, and very similarly, people are saying, if we've known about monkeypox a lot, why have we not got any vaccines? Well, we do have smallpox vaccines, and we know that these may be effective in protection, both pre and post exposure to monkeypox. And the Invanex vaccine, which is approved in Europe for smallpox, we know that this is 85% effective against monkeypox. So we do have a vaccine that is available and can be used within the UK. But there is no doubt, and we are very aware that within the labs as we speak, there is ongoing work to develop more bespoke vaccines. So what should you do if you have symptoms? So we are saying to call 111 if you after speaking to 111, if you're very unwell, then they will organise for you to go to A&E. And when you're going to A&E, that will generally be by ambulance, and the ambulance crew will know to take the right necessary precautions, because you will be managed by people wearing protective equipment as well. So that's really important. And if you're not specifically unwell, but you do have symptoms, then it's also advised that you contact your local sexual health clinic. But the key thing is that you should not walk in. So you should contact these services before going in, because if you are, let's say you're coming to my clinic today and you do have symptoms, we are screening at the door, and you will not be allowed in until we are assured that we have the right space to look after you and test. Otherwise, we will ask you to wait. We may ask you to go to A&E if you're unwell, or we may have to book you an appointment to come in, so that we can manage you in the right way that minimizes any risk of exposure to staff and other members of the public as well. There is also a national helplines as well that have been put into place. And so these also give an opportunity for people that are seeking any advice and if they have any concerns as well. And when we're outside of this long weekend as well, it's your GP, it's 111, and also contacting your local sexual health clinic. So I'm just wanted to emphasize that monkeypox is a notifiable disease. And one of these things is that when we talk about infections that can sometimes make people, you know, less likely to present and are worried about what happens. Just to say, because it is an infectious disease, so that the UK Security Health Agency will need to be notified, and it's currently classified as a high consequence infectious disease. And so when someone is positive, and there may have been contacts of them, the UK Security Health Agency have health protection teams, and these will be contacting people that are potential contacts, and then these contacts will be risk assessed. So, and it will be decided whether these people remain well, and if they can isolate, and how can they be supported, and if they require vaccination as well. So those that have the infection will be managed, but also their contacts will be as well. And I think this is important to convey, because sometimes people will worry, people will be contacting me, or I don't want to let my contacts know. But this is the reason why, so that we can contain any onward transmission and how the virus is passed on. So just coming to the end now, and just so that we can have an opportunity for questions and discussion. But just thinking about some of the common questions that have come up. So is monkeypox related to smallpox and chickenpox? So I've said it's related to smallpox because they're both orthopox viruses. So they're a certain type of virus, but it is not related to chickenpox. So despite the name, chickenpox is caused by a herpes virus and not a pox virus. And how chicken got into the name is not entirely clear. Haven't been able to find that out. But it's the vesicles and those fluid-filled blisters that I've described that are caused by monkeypox that are similar in appearance to those of chickenpox. So that's where that similarity comes. And are cases likely to continue rising? So, one of the things I always used to say in COVID is that we are learning together, and we are trusting science together, and knowledge is evolving. I think that it's likely that cases are going to continue rising over the coming weeks, but it's difficult to predict further. And there is a lot of modeling and monitoring, as I said, that's happening in the background for this. And I'm sure as the days, weeks progress, we will be given more predictions and more information about how it's evolving and how it's impacting as well. And we are also piecing together the data from all the other places across Europe, America, Canada, where we are seeing cases, piecing this information together to see how the scale of increase, to understand the scale of increase, I should say. One of the things is that, I explained that it's from close contact, it's from droplet transmission, with coughs and sneezes, but it doesn't spread as easily as the airborne virus, SARS-CoV-2 with COVID-19. So that gives us some indication, but as I want to emphasize, we are still learning. And I've commented a lot about stigma, but I think it's so important because, first of all, I said earlier that it has been mainly, but not exclusively, being seen in men who have sex with men. And so instantly that brings that association with the gay LGBTQI community, and then that leads to stigma itself, to othering, and really confusion about transmission. So rather than people focusing that it can happen to anyone, that it's skin-to-skin contact, close contact, it's focused on sex and the sex between men. And I think that is worrisome, because then it detracts from the truth of what is happening. Also, there's this stigma against Black people and people, migrants from Africa, and I'm sure some of us, and hopefully not all of us, but I'm sure some of us have heard, some disparaging remarks about it, and flippant remarks saying, oh, it's an African disease, etc., and it's just been passed over. So it's, again, ignorance stops testing, ignorance stops awareness, and this is something that we really, really need to tackle head on as a community. Because all of this then feeds into conspiracy theories and misinformation. And, the information that I've given today is the information that we have. That's the truth of the matter. And we are learning, but we are not dealing with something that we have not known about. We have known about it, but it's different for the reasons that I've explained earlier. And there's a great scientist and an infectious disease doctor from Cameroon who works in Atlanta, Dr. Tajani, who has talked, highlighted this. And I think it's really important to say this. So she says that the recent outbreaks are kind of the culmination of years of warnings that basically went ignored. Because unfortunately, monkeypox is a disease that has traditionally caused outbreaks in Africa, and usually in very remote parts of Africa, and affecting populations that the world doesn't always care about. And you see, this is one of the problems with stigma and othering, is that it is quite easy to dismiss and not acknowledge people and infections such as this. So it's important that it's not just put into isolation in a certain area, that people recognize this, that with globalization, it affects everyone. And so we need to be aware, we need to be attuned to viruses in all their entirety. So what are the gaps in our knowledge? So what are the transmission factors and patterns that cause this? Why has it suddenly emerged in countries outside of those endemic areas? What is the extent of undiagnosed infection in both endemic and non-endemic countries? Is there more circulating virus that we just are not aware of? In terms of immunity, so once you have it once, are we immune from further infections? What degree and what lasting protection does vaccination give? And also, what are the best interventions to prevent severe disease or death? And also, what are the best interventions to protect us as well? And so what next? So the WHO has real key priorities, and I think this is in line with us all. It's about raising awareness, it's about identifying cases, it's stopping transmission, and then also protecting health workers and preventing transmission in healthcare settings. And I'm just going to end here with Professor Fenton, who we all know well, who is the London Regional Director for Public Health. And I'm just going to read what he says, because I think, as ever, sums it up beautifully and just kind of sets it the right scene and tone. Monkeypox can affect anyone, but we know that many of the recent diagnoses are in gay and bisexual and other men who have sex with men, many of whom live in or have links to London. We're reminding everyone of the symptoms of monkeypox, especially gay and bisexual men in particular, to be especially aware and to seek advice immediately by calling 111 or their local sexual health clinic if they have concerns. As with any new disease outbreak, the risk of stigma and uncertainty is great. And this is why, we are working with the NHS, sexual health, voluntary and community sector organisations in London to share accurate information about monkeypox, especially to people and to groups at increased risk through representative voices. And so it can affect everyone. We know that there are specific groups that are being more affected, but the key thing is that the risk of having stigma and uncertainty is great, and we have to be really mindful of this. And thank you so much. I'm going to end there and time for questions.
Great. Massive thanks, Dr. Vanessa. That was really, really insightful. I will hopefully bring in Angela, who has quite a number of questions from our community, and she will be fielding them. But before I bring in Angela, Dr. Vanessa, can you talk a bit more, because I know you talked about transmission in pregnancy, and I was wondering if you could enlighten us a bit more about that. And if so, what's the risk for the newborn baby?
Okay, yeah. So one of the things, the key thing about pregnancy is the placenta, and where it's the interface where the mother and the baby, and they're sharing blood essentially, and so if the mum has the monkeypox virus, there's a potential for it to pass through the placenta and can affect the newborn as well, bringing similar complications as we've described as lesions and complications in the chest or infections in the brain as well. The key thing is, I'm happy to say, is that we don't see high numbers of that for a number of reasons, but that potential is there. So like anything, when someone is pregnant, you're thinking about them and you're thinking about the fetus or multiple fetuses that are there. But being pregnant itself is immunocompromised, as we say. So your immune system is slightly lower when you are pregnant. So that's why we always encourage, if someone is pregnant and we want to minimize the risk of them being exposed to someone that has chickenpox, someone that has other infectious diseases. So in that way, monkeypox is very similar to that. So we don't want pregnant women to be exposed or have the potential to be exposed to monkeypox as well.
Great. Thanks, Dr. Vanessa. Angela, over to you.
Apologies for the delay. I wasn't able to unmute. Good morning, Dr. Vanessa, and thank you very much for a very insightful and informative session. Just a few questions for you, if that's okay. You talked about the fact that monkeypox is found in kind of Central and West African countries. One of the questions that's been sent to me is this as a result of experiments? Because we know that experiments are normally carried out within the most poorest countries, and we saw this with HIV/AIDS and other things. So is the monkeypox as a result of some kind of experiment that may have gone wrong or whatever?
So that is such an important question, and I'm really glad you've asked that, because that's another question or thought that people have and they may not ask. So what we know is that actually it's predominantly in animals, and so I mentioned in terms of rats and squirrels, etc. And what we believe is that, like with some other infections, in the UK, we don't even think of those animals as nourishment in any way. But in certain areas, it's as a bushmeat, and so some people will do those, and that's their access to meat. And so what we believe is that that's how it crossed from animals into humans, and so it's not from experiments at all, but from that crossover. Now, one of the things is that, whenever we give these answers, we never dismiss those thoughts that people have, because there have been examples where things like that have happened. So I never dismiss that. But what I say is, what we know about monkeypox specifically is that it is the crossover from animals into humans. And that is inevitable, because that's we are predominantly carnivores. And so things will move from species. Yeah.
Thank you very much. The other question that I do have is, as we have seen with the situations like the COVID-19 pandemic and the disproportionately affected people, or of the Black community, does this follow the same vein? Are Black people more susceptible to monkeypox, or is it everyone?
So again, another really great question. It's everyone, and the thing for me about this is that, and it's those added layers, is, I said it's close contact. Okay, so one of the difficulties is that if we don't contain it now, what the potential is that one of the things we did see in COVID is that for many people from those of Black ethnicity, Asian ethnicity, one of the examples is that we're in multi-generational households, or we're in living conditions or work conditions that we find it hard to isolate from each other. And so if we are in situations in which there are more possibilities of interactions, then that may put us at increased risk of acquisition, so acquiring it and passing it on. But as a disease itself, and actually what we're seeing at the moment, it affects everyone. And ethnicity does not come into play. And so in the flip side of it, if we were seeing it in Africa, and we think it's from, could be from bushmeat and things like that, we know it's been mainly contained there. Do you see what I mean? So that's something for us to put into context. It's been there for many years, but it's also been contained there. But then something different has happened, and we need to understand why it's happened, why the change, but it affects everyone. Yeah.
Okay. Just one more question, if I could. And this is mainly around the health issue, because obviously with COVID, people who have had underlying health issues were again more susceptible to the COVID virus. Is it the same for monkeypox? Is it similar?
So what I would say is yes. So one of the things is that when you have other conditions, you not only have the condition, but you can also have the medication that comes with it. And all of that may make your immune system or your resilience, your body's resilience, not as high as someone that has a fully functioning immune system or has no other conditions as well. So we are very aware that those that may have other health conditions, we want to just keep an eye on them a bit more closely, and just be aware that they could be at increased risk. And that's why people that are pregnant, I use the term immunocompromised, and that kind of encompasses that aspect of having other health conditions, having other medications that can alter your immune system, and that can put you at risk of getting it. But really, it's having more complications. And so we want to minimize it so that it's a mild, self-limiting illness that it mainly is in most people.
Just one more question and then I'll finish.
Oh, no, please.
It was around the 21 days obviously, I mean, with COVID, we heard about 14 days isolation that was then reduced to 10 and then reduced to 5. But we're talking about 21 days. Does that mean that monkeypox is a more serious virus than COVID, or why the length in isolation?
Yeah, no, it's funny. You know why I'm just smiling? Because I'm just remembering all those isolation periods. It's funny how you block things out of your mind. But yeah, no, definitely. So I think one of the things is that it's the pattern of how viruses work and how they multiply, and how they can still evolve in your body. And it's like with syphilis, that's a sexually transmitted infection, and that can take for anywhere from 9 to 90 days before you could get symptoms. So it's not necessarily about how aggressive the virus is, etc. It's the pattern of evolution, the pattern of how it works. And you see, that is why it's so important that we need to understand these viruses.
Yeah.
Because otherwise we go into it blinded and we'll be like, okay, you know, I saw someone, it was a week ago, but that's fine. I haven't got any symptoms. It's okay. And then you go out and about and then you get it a week later. But in that time, you passed it on to many people. So it's just about the pattern of how it works. And what we understand so far is that it is 3 weeks. But as you highlight, and you know, I'm so glad that it's, you know, it's Jubilee weekend, so not everyone wants to be listening to everything about monkeypox. But the thing is that it's good to get the information out early, because what we had in COVID is that because information kept changing, everyone was like, what is this? You know, why do we know, why are we saying this now and it's different to later? That what we know, what we are telling you now is what we know now.
Okay.
And it may be that in days, weeks to come, we know something different. But as of today, we understand it to be up to 21 days.
Okay.
Yeah.
Thank you very much, Charles. That's my questions done. Thank you.
Right. No, thanks. Really, really important questions, Angela.
Thank you.
Dr. Vanessa, you know, a few more questions coming up. There's one in the chat box, which I think is really, as a pregnant woman who has a school-age child who could be at risk of contracting chickenpox, what can be done to prevent the adverse effect on the mother and unborn child? Are there any vaccines that you would advise a pregnant woman, you know, to have?
Yeah, no, again, no, these are all great questions. So at the moment, I mentioned that there is a vaccine, and I also mentioned that if someone is a contact of someone, a known contact of someone that has monkeypox or is at high risk of having monkeypox, then you're contacted by the Security Health Agency to get the vaccine. Now, we are currently not at a stage where we are routinely giving vaccinations to people just because they fall into certain categories. So if you are pregnant and you have your school-age child oh, sorry, is this just about chickenpox or monkeypox?
No, well, chickenpox.
Oh, actually, sorry. So I launched into monkeypox. I'll finish talking about monkeypox and I'll go into chickenpox. But so for monkeypox, we're not at a stage that we're routinely giving vaccinations to people. So it's we're number one, there's not enough. We're getting more vaccines. Number two, it's mainly contacts, and that's staff and household contacts. But also we are hopefully moving into a phase where staff that are working in high risk areas, so such as sexual health, such as ID, will have access to prophylactic, so preventative vaccine to take, so that it gives them protection as they're caring for people with potential monkeypox. Now, for pregnant women that have that the question is, I think, specifically about chickenpox. Is that right? So there are vaccines that are available for chickenpox, but they are not typically always given in pregnant women. And so I always ask, I always say to women that if they are concerned and they haven't already been vaccinated and or haven't had chickenpox, so they should go to their GP to discuss whether they can have the chickenpox vaccine. There is a vaccine available, often many adults have had it and they don't realize. So sometimes what happens, and you can have it in your booking bloods, is that they will check if you've got antibodies to suggest whether you've had chickenpox before and you've not known about it. And if you haven't had it, then you'll discuss it with your GP or your midwife about getting access to it. And there is no specific safety concern either for the mother or the baby when the chickenpox vaccine is given during or shortly before pregnancy.
Oh, thanks, Dr. Vanessa. I never knew. You learn something new every day. If I knew there was a chickenpox vaccine, I'm sure I would have asked for that, years ago. Right, I came across an article, I think it was in Nigeria, where they're trying to cut down on bushmeat so that people don't contract monkeypox. Is there any connection? Could you get it from?
Yes, and so it's interesting because there are more studies like this coming out. So as I said, it's predominantly had been seen in animals, and we think it moved from animals to humans through nutrition, so through food, and that is what we typically call bushmeat. And so it's, one of the things about this is raising awareness that, number one, that animals do have infections. Number two, that if an animal has an infection and you ingest it and you eat it, it can also affect you as a human. But not all that messaging has really gotten out there. But the other thing I always say with this is that it's good and well to explain this to people, but you also have to explain to them how they're going to get nourishment if they're not going to have the bushmeat, because there's a reason. It's not just taste. There's a reason why they're having bushmeat. That may be their main way of accessing protein. So but there is a lot of work that are happening in some of those settings, just to say, to raise awareness and to say, right, this is a possibility. So to minimize this possibility to cut bushmeat. So yes, there is some work there. I've also got a question from the chat, from YouTube.
Yeah, Angela is going to ask that question.
Oh, okay, great.
Apologies, I was again trying to unmute. So from YouTube, the question was: Is the monkeypox going to support the research into other epidemics of this kind? Will it help those smaller countries, those countries that are affected, and really we don't hear about them normally until there is a situation of this kind?
I truly hope so. I think that, and I mentioned it in the presentation, that, there are so many neglected diseases. There are so many diseases that are happening in many parts of this world that we would not even know the name of. We would not know it exists. And there certainly isn't funding to research into it. And that is unacceptable. And it is also unacceptable that we are only now having the conversation because it is now affecting us. And for me, I talk about othering a lot, because in life, it's so easy to other and rely on difference for separation and be blinded to things and ignore things. And monkeypox it just highlights that we cannot ignore one another. We are all interconnected, thinking of all the 6 degrees of separation. We are all connected in so many ways. And in the same way that we take the good from each other, we need to take those things that may not necessarily give us comfort, but we need to support each other, because we are all interconnected. And so I really hope that we raise awareness, that we have these discussions, and that it focuses savvy commercial companies to think, if I were in a pharma company now, I'd be thinking, you want to get ahead of the curve. So you want to invest in these diseases. So if it does spread, then you've got the drug that can treat it. So that's the kind of energy that I think we need to have about these things. And unfortunately, in lower and middle income countries, it is not for lack of education there and resources there in terms of academic brilliance. It's about financial resources and investment. And so what would be great is that it raises awareness that you not only have to invest in researching into these areas, you have to invest into the researchers within these countries. So that, and you also have to invest into the healthcare systems, that because if you're going to be researching into monkeypox, you know, there is no point in researching into it if you do not have healthcare facilities that can look after those with monkeypox. You know, and that's the thing. And so it's all interconnected. So I would really hope that in the same way we talk about health inequalities now on far more, I hope that we talk about those, you know, neglected areas of the world that need more research, so that we can, health, you know, will be something that everyone can achieve, definitely.
Thanks, Dr. Vanessa. And can I ask you, who are you seeing coming through your clinics in regards of ethnicity? Are they people who have returned from overseas, or?
So interestingly, and being, you know, very candid, I'm seeing a lot of white gay men. I'm seeing, and then I've got a snapshot of those that have returned from all parts of Africa as well, and also parts of the Caribbean, because, you know, everyone is thinking, yeah, I've got a fever, I've been somewhere, yeah, it's not in Africa, but it's raising awareness. And for me, I'm glad about that, because I would rather people not sit at home and just be unsure or be nervous about it and have it in the back of their mind, but rather being proactive and saying, let me come in and check, let me just see. And so but we are predominantly seeing it in gay men. But that is, again, you know, what I've been really, really firm about is that we are a sexual health service, and there are some communities that are more comfortable to come to a sexual health service, and those typically are gay men. And so they have recognized it early, they've seen it, and they know, where can I go to? I'll go to my sexual health service. They've been really pivotal about raising awareness within communities, to say, right, if you've got it, no shame, go to your sexual health clinic, go and get tested. And I think that momentum has been pivotal as well. So yes, we are seeing it in a lot in that group. Yes, it is likely being spread a lot within that group, but also the key thing is that they are also presenting. And so the concern is that there are people that are not presenting that have it. And so we need to, that's why we need to know and encourage that it can affect everyone.
Thank you so much, Dr. Vanessa. And another question from you two. How close are we to developing a vaccine for monkeypox? I know that you did mention a vaccine earlier in your presentation, but given the potential seriousness, you know, how close are we?
So I think that we are quite close now. What does close mean in this world at the moment? Because so people are saying, right, you know, what we did with COVID, are we going to replicate with monkeypox? Because if it's been here for years, then why haven't we done it? And I completely get that. And there are a number of, you know, as we said, political, financial reasons, etc. But there is a lot of work happening in the background. So instead of me saying definitely, I know it's going to be in, you know, 2 months, 6 months, 3 weeks. What I'll say is that I would not be surprised that in the very near future, in coming weeks to months, we are told that there is a vaccine against monkeypox that we will have access to. And, you know, then we go through the vaccine engagement in a different way again. But that also depends on how the numbers go. And if they rise up significantly, etc. Because as we know, the thing about COVID is that it rose exponentially. And it went out of our control extremely quickly. At the moment, it is contained, but the numbers are still going up.
So it's important that we raise awareness now and give the information that we have now. Dr. Vanessa, thank you very, very much. Thank you. I have pleasure in handing over to Charles. Thank you.
Yeah, thanks, Angela, for that. So, Dr. Vanessa, we're about to wrap up. Just checking, just like COVID, can someone have, you know, can someone have monkeypox and not know that they have it?
So again, so that is a very good question. So we are trying to understand more about what we call asymptomatic presentation. So those that don't have symptoms, you can understand that we are in a phase where most of our understanding is from a finite set of numbers within the UK and Europe and America. And then we've got some understanding from what has been happening previously in Africa as well. And the predominant cases do have symptoms. But the issue is, and why we are being alert, is because you don't know what you don't know. So it may be that there's more influence of those that don't have symptoms in how this has been, why the numbers are going up. We don't know. But at the moment, it is predominantly it's predominantly an infection that we see symptoms in. Yeah.
Great. So it's been a real delight co-hosting with you, Angela. I hope there's a beginning of many more to come, and apologies for putting you on the spot.
No problem.
Dr. Vanessa, before Ngozi comes in, take-home messages.
So I think the take-home messages are that this is a virus that we've known about for a long time, but we are seeing it within the UK and other parts of Europe and Americas. That and this has been surprising to us. It can affect everyone, but we are mainly seeing it at present in amongst men who can have sex with men, but it can affect everyone. The key thing is that if you do have an unusual rash, you do have fever, headaches, body pains, and you've either recently returned from West or Central Africa in the past 21 days, you may have had contact with someone with monkeypox, or you're a man who has sex with a man, please go speak to 111, contact your local sexual health service, contact your GP, and speak about it and organize to get tested. There is no shame in this. The key thing is that we need to diagnose people so that we can contain the transmission and passing on of the virus. And it is mainly a self-limiting mild illness, but there are severe cases. So it's so important that you get tested if you do have symptoms.
Great. Thanks, Dr. Vanessa Apea, once again. Over to you, over to you, Ngozi.
Thank you very much, Charles, and thank you, Dr. Vanessa, for today's insightful presentation. And thanks, Angela, for helping out with the questions as well. I'm just going to run you through our events for next week. Thank you. Thanks, Angela, for sharing. So next week's topic is prostate cancer awareness. So it's something that, our men live with, and we really do want more people to be aware of this. So please join us next week at the same time from 11 to 12:15 next week. If you need more information, please email us at health@cahn.co.uk. Thank you. Next slide. And next week, Tuesday, we've got our Healthy Hearts session. It's going to be a very exciting discussion, and it will be facilitated by Dr. Hiba. So next week, we're talking about sharing healthy food practices, and we've got 4 people on the panel. I'm really excited about this. So they're going to share their food experiences. So please join us next Tuesday, 7th of June from 6 p.m. to 7:30. Next slide, thank you. And on Monday, we've got our gambling awareness session. This addiction is growing in the UK, and it's something that we're not really aware of. So it's really good if we can sign up to this. It's happening in a couple of days' time on Monday. Please do join us. If you need more information, email us at communityengagement@cahn.org.uk on Monday, 6th of June from 6 p.m. to 7:30. Next slide. And we've got our volunteers event on Tuesday as well. So from 4 p.m. to 8 p.m. is going to be a face-to-face event. We really do value our volunteers, and this is Volunteers Week. So if you know anyone, or if you're on this call and you'd like to join this event, please join us. It's at MAV UK at Jarvis Road in Manchester. Please join us. And with this as well, you can let us know if you want to become our volunteer for any of our events, and even our Windrush, that's Windrush event coming up in June. So yes, we are happy to receive you, which leads us straight into Windrush. So this is June now, we're already there. So come 25th of June at Alexandra Park, our Windrush event is happening live, and it's going to be lots of fun and lots of events and to learn more about the Windrush. So please join us on the 25th of June. And if you haven't, if you need a stall, please register today at windrush@CAHN.org.uk and tell us if you require a stall. We're happy to welcome you. And last but not the least, our amazing services. We support people with counseling services, family advocacy, support, and domestic violence services. Feel free to call us on 07710022382. We are here 9 a.m. to 9 p.m. every day, so please feel free to contact us. Thank you so much once again for joining us today, and we look forward to seeing you again next week. Thank you, Dr. Vanessa. Thank you, Charles. Thank you, Angela. And thank you, everyone in-house as well. See you next week. Thank you. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on health and topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members, such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.